Hi everyone. So I know elective season is starting up for senior medical students in Canada and the US that are interested in ophthalmology and are entering the residency match cycle this upcoming year. And so I get a lot of questions about how to prepare and what sort of skills and knowledge is important for elective students to know. And also got some requests for a longer version of the talk that I recorded earlier this year. And so I thought I would record this talk that we give to some of the clerkship medical students who rotate through our department on an approach to the red eye with more of a focus on some higher level topics and concepts that are relevant for elective students. Because I remember as an elective student, there is sort of a gap between material that's meant for a basic medical student, interested in any specialty to know, irrespective of whether you're specifically interested in ophthalmology. And then there are resident level resources, which can be a bit challenging to really get a grasp of in the limited time you have to prepare for your electives. And so hopefully this can try to hit a intermediate between those levels of knowledge and will give you a foundational approach to the red eye for your ophthalmology electives. Now it's an important caveat that although red eye is a very common presentation you'll likely see on your electives, it's not the only presentation you'll have to know how to address. This talk will not go over, presentations related to the retina, for example, or neuro-ophthalmology, which are also very commonly seen in an emergency eye clinic, for example, and that you may see in your electives. And so certainly supplement the knowledge from this talk with other resources. And so an outline for this talk specifically is first we'll go over some anatomy, a little bit about the history and the exam, and with a focus on some things that I think are important for elective students to have a good grasp of, and an approach to the red eye. And so we'll go through it anatomically and focus on some of the important diagnoses to think about and to have some sort of familiarity with as you go through your electives. And then finally, some red flag symptoms to always be thinking about when you see a patient with the red eye. I think especially as an elective student, it's important to ground your approach in what sort of the critical things to address on your assessment, and then some of the more nuanced or rare diagnoses you can go over with your senior resident or attending staff, and then finally a summary. And so when I give this talk to the medical students who rotate through, we make this interactive by using Kahoot, but we won't be doing that for this online talk. And so I think a really critical part of understanding disease conditions in ophthalmology is to really sort of conceptualize the disease in terms of the anatomy in your head, because I think the anatomy can really help you sort through what you think may be the cause of the patient's red eye by looking at the eye and how the eye responds and the symptoms that the patient has. So starting exteriorly in the top left, the white part of your eye that you see is the sclera. That's the actual white tissue, but I think it's important to realize that even though what you see is white, there's actually many layers of tissue that you're looking through, because the most superficial layers of the eye in that area are actually transparent. And so it's not apparent on this picture, but the first layer you look through is going to be the conjunctiva, which is normally clear in non-disease states and has blood vessels that run through it, and that obviously can be inflamed in conjunctivitis. And then below that, you have the episclera, which is a layer of tissue that lies on top of the sclera, which is also transparent in color, and that can also be inflamed in conditions like episcleritis. And then finally, you have the actual sclera itself, which is the white part that you physically see that is the protective coating around the eyeball. And so, for a patient with a red eye, for example, any one of those layers can be inflamed, and we'll go into a bit later how you can sort of parse out which of those layers you think is involved. And moving to the center of the eye, the first layer that you look through that's also clear in nature is the cornea. And so in a non-disease state, that should be completely clear, which gives you a great view of the iris, which is the colored part, and then the pupil, which is the black center part that allows light to get into the back of the eye. And so diseases of the cornea can also result in red eye due to irritation, and we'll go into some of the important diagnoses for that. But it's important to understand that in a non-disease state, the anterior chamber, which is the complex which involves the cornea, iris, pupil, and the aqueous humor that is within it should be clear in a non-disease state. And so if that is not the case, it points to pathology within that part of the eye. So now moving a bit posterior, the next part of the eye that light travels through once it goes through the pupil is the lens, which is not as relevant when we talk about red eye. Perhaps it is when we think about acute angle closure glaucoma. That lens at birth is a sort of oval shape and makes up a portion of the refractive power of the eye. And in some rare cases, which we'll get into when we talk about angle closure glaucoma, that lens can push some of those structures forward and close off the eye. But aside from that, there isn't too much to think about in terms of the lens and disease states causing red eye. Now, that was all what we call the anterior segment of the eye, which is essentially the structures in the front part of the eye, which are also the parts of the eye that you can see and that contribute mainly to red eye. The rest of the eye posteriorly is, within the orbit. But that's not to say that in a patient with a red eye, you don't have to think about the posterior segment at all, because many pathologies that cause red eye can also have posterior segment involvement, involving the retina or the optic nerve. And so, we'll highlight this as we go through, but just because you see a patient with a red eye, it's still important to examine, the retina and the posterior segment to make sure there is an involvement of that area of the eye as well. So, moving posterior from the lens is the vitreous humor, which is that jelly substance, which actually makes up the majority of the volume of the eye, which again should be clear in normal disease processes. And then in the back of the eye is the retina, which if you notice, there's those layers there, the retina, the choroid, and the sclera. As you can see, those layers are actually contiguous with the anterior portion of the eye, which I think is just an important thing to keep in mind and can help you remember in your mind that pathologies that affect those structures anteriorly are continuous with the back of the eye. So in many cases, inflammation and redness that is affecting the front is also affecting the back of the eye in a sense. So that's why it's still important to look at the back. And then of course, the part of your eye that connects your eye to your brain is the optic nerve, and that carries the neural signals from your retina to your brain. So I think it's just important to conceptualize the anatomy of the eye, and also just keeping in mind that the posterior segment, such as layers of the choroid and the sclera, are contiguous with the anterior portion, which becomes red in cases of red eye. And so for an ophthalmic history, we try to keep this simple for the clerkship students who come through, but obviously as an elective student, you may have to ask a few more questions in this. But I think the couple of things you always want to nail down and sort of be able to imagine yourself as the patient and walking through the disease course, and these questions are critical for cases of red eye, is the time course of how their red eye started. So whether it gradually started over the course of days, whether it was very sudden, and whether it comes and goes. Those couple of pieces of information are really helpful in narrowing down what might be the cause of their red eye. Whether it's affected, one or both eyes, and also the relative sequence, whether it was both eyes at the same time, one eye and then the other, whether it is one eye today, but they've had episodes of red eye in the past in the other eye. All those pieces are really important as well, which we'll get into. And then other pieces on history, I like this acronym RSVP when thinking about the symptoms you always want to ask every patient. Of course, they're going to have redness, but photophobia, sensitivity to light, vision loss, and pain are all super helpful. Oftentimes, just based on the answers to those couple of questions, you can also narrow it down. And we'll get into some questions on history to ask with specific pathologies, but I think at the very baseline, these are the questions you want to nail down and have a good understanding of what the patient's experiencing. And so again, this is a sample ophthalmology note, which you should certainly be familiar with going into your ophthalmology electives, not only for writing your own notes, but being able to understand the notes that have been written by other people when you're seeing these patients in follow-up. And so this will be a bit different now that a lot of institutions have moved to EMR, but they still roughly follow this similar structure just because this is the way that most residents and staff sort of understand these pathologies in their mind. And so the main parts that I'll highlight that are a bit different than other specialties, I think is really the exam section is the thing that's most different. And so as you all mainly know, the ocular vital signs are the visual acuity, pupils, and intraocular pressure. I think sometimes these things get glossed over a bit, but I think they really are critical in trying to get a sense of the urgency of a patient's presentation. And so certainly always checking those is important. I think confrontational fields as well is important to do as well, extraocular movements, and the slit lamp exam. I think one thing that I would highlight as an elective student is whether or not to dilate the patient, because typically to get a good view of the back of the eye or the fundus, you want to dilate the patient so that you can take a look at the retina, and this will sort of differ between centers and institutions. But I think a general comment is get a sense from your residents or staff what their sort of preference is. Some institutions will want the elective student to always review the case before dilating the patient, just to make sure there isn't any reason to take a close look at the pupils before you dilate. Some centers will give you a bit more freedom to dilate the patient yourself and work them up. Off the top of my head, some conditions that I think are really important not to dilate the patient before getting them reviewed by someone a bit more senior would be cases of uveitis, for example, just because dilation in itself can alter the amount of cells or particles in the anterior chamber, which we'll get into, which in cases of uveitis is really important to have an accurate sense of how much inflammation there is in the AC, and dilating the patient disrupts that. And there's also potentially iris nodules on the iris in cases of uveitis, which are hard to see once you've dilated the patient, and so people typically want to take a good look at that as well. So that's one case that you shouldn't dilate for sure. Other cases would be acute angle closure glaucoma, typically because the angle can actually become more closed off if you dilate the patient in those cases. So certainly don't dilate the patient in those cases. And really any pathology that you think there might be involvement of the optic nerve, I think is important to get a good pupil exam first. Make sure there isn't an RIPD before you artificially dilate the pupil, and you can't get a good sense of what the baseline pupil response is. So when in doubt, I think as an elective student, it's always safer to just get the patient reviewed by a senior first, just because it's one of those things where I know there is sometimes an incentive to be fast and thorough with your assessments as a student, but you'll save yourself a lot of headache by not accidentally dilating the patient prematurely and then having to bring the patient back for another visit. And then sometimes it really makes a big difference to the patient's management. So just something always to think about. Yeah. So moving on to our first anatomical category here are causes of red eye from the eyelid. The first one we'll talk about is blepharitis, which is super common, as many of you know. Most people have some extent of blepharitis, but it can be surprising like how severe some of these cases can get. And in the severe cases where people are coming in with very inflamed, angry eyes, from this, I think, part of your assessment should be looking for potential reasons for patients getting blepharitis. And so I think a big one to look for is rosacea and asking patients about that, which especially nowadays in the age of masks, it can be hard to see because typically rosacea, as many of you know, patients typically have rosy cheeks, telangiectasias on the cheeks. Some patients can get involvement of their nose, but nowadays many of your patients are coming into clinic with a mask on, and so a patient with potential rosacea, you may not be clued into some of those findings because patients come in with a mask on. And so certainly, I've seen multiple times where a patient comes in with blepharitis and people don't really know why it's so severe, but you get the patient to take off their mask and, it looks like they may have some rosacea that's been undiagnosed, and then you can refer them, and the treatment is slightly different if you think rosacea is the underlying cause. I would always ask about recurrent chalazion stye, which we'll get into, which can commonly occur in these individuals. And I'd also just generally ask about autoimmune conditions like Sjogren's syndrome can cause some blepharitis and dry eye. And so always asking about some of those systemic treatments, I think, is a way to take your assessment to the next level. Oftentimes people just have idiopathic blepharitis, but I think if you're able to kind of tease out all these other sort of secondary, more rare causes, that can make your assessment more thorough. And so I would always look at this, and I feel like sometimes in red eye, the eyelids get a bit ignored, but as you pointed out during the exam section, a slit-lamp exam is critical, and looking at every part of the eye is very important. And so there's the treatment there. The other thing that I would include as an elective student that's always helpful with this sort of workup is if you're thinking this is a patient who may need a tetracycline like doxycycline, I think it's important to ask to kind of think about like a step ahead of whether this patient has any contraindications to doxycycline. So always asking about family planning. Many of these patients may be young females in childbearing age, and so asking about family planning, asking about like sun sensitivity, previous reactions to antibiotics, because if you already present to your attending that you've kind of thought ahead that this is a patient that may benefit from doxycycline, and you've already asked about all the contraindications, I think that's always a helpful way to show your understanding of the disease pathology, that in your initial presentation you've already kind of thought ahead to the management. And so the treatment for this, as many of you know, a lot of it is based on lubrication, and I would also add warm compresses as well to dry eye management. But this is something you'll become very familiar with as you move through your rotation, just because this is such a common condition. The next pathology that we'll focus on is stye or chalazion. These are also very common and can cause red, irritated eyes. Many of you have probably already seen this. These are small red lumps that grow on the base of your eyelids or eyelashes. The treatment for these are effectively the same. A lot of it is related to warm compresses and really just trying to help the eyelids sort of naturally flush themselves out. We'll get into a slide a bit later differentiating the two, but just to realize that practically the treatment is essentially the same and really is reliant on warm compresses. This is a picture of how we remove some of these chalazions that are ear-resistant to treatment. Typically we take them out from under the eyelid just because prevent scarring and things like that. And an analogy here is like scooping out ice cream. And so hopefully you get to see one of these during your electives. And so just to differentiate the two, like we said, practically the management is the same. So this differentiation always isn't helpful, but it's helpful if people ask you questions, or it could be on exams and things like that. And so I think conceptually I would just imagine that a stye is an infectious process, where a chalazion is really just blocked oil glands. And I think if you just remember that in your head, it's like easy to kind of pair up the symptoms that go with each. So because the sty is an infectious process, think about like a cellulitis that you may have seen on your emergency rotations. Those have, swelling associated with them, and they're typically quite tender. Infections are typically painful. And so just remember that those are often painful when you press on them. Versus a chalazion is really just a blocked oil gland, and it's typically a lot more firm just because that oil is all packed together in the blocked gland and is often painless. Patients may have a little bit of discomfort just because they have that blocked gland there, but it shouldn't be painful like when you just put your finger on it, similar to how an infectious process would be. So just, a good way to remember the two. The next pathologies we'll talk about are cellulitis or soft tissue infections related to the area around the eye, so the periocular area. I think a really critical distinction, and this is like absolutely critical for your electives, is to understand the difference between preseptal and orbital cellulitis. So here's a cross-section of the eye with the periocular structures, and the anatomy of the eyelids is such that, especially in the upper eyelid, there's a connective tissue layer called the septum, which separates effectively, the superficial layers of the eyelid, which is, everything in front, and then behind is what we consider the orbit. And the orbit is what contains, the eyeball, the extraocular muscles. Way in the back is where the optic nerve is. And that connective tissue layer is helpful because it sort of serves as a artificial boundary such that typically, if an infection happens on one side of the septum, it sort of acts as a barrier. In really severe infections, that barrier becomes broken. But when you think about infections around the eye, think about whether it's happening in front of the septum or behind the septum. Because the management for these two is quite different, and the severity is quite different, where infections behind the septum, or we think are in the orbit, are typically a lot more serious, and that we have to treat a lot more aggressively. So we'll talk about on exam how you try to differentiate the two, and if you see a patient with an infection around the eye, the resident or staff physician that you review with is going to be very interested to know that you've tried to delineate whether you think this infection is extending behind the septum and whether you think it's in the orbit. So first, starting out with preseptal cellulitis, which thankfully is the less severe but also more common of the two. And so, symptoms include eyelid swelling and erythema. And so you can see those pictures on the left. And I think the important thing to remember is that sometimes, this eyelid swelling can be really severe. Like their eyelid can look huge. But it's important that you go through the rest of the exam to figure out whether there's involvement behind the orbit. Because as we were saying, there's a septum that separates the superficial layers and the deep layers. So someone can have as much swelling and erythema as they want, but if you don't have these other findings that point you towards an orbital process, it's still a preseptal cellulitis. It's just a really severe one. And so I think that's, often an important thing to trip up. The amount of swelling and redness that you see doesn't necessarily correlate with whether there's orbital involvement. And so a preseptal cellulitis, they need to have all of these things. They should have a normal visual acuity because this is all superficial and not really affecting the eyeball. So their eye can still see normally. This is not necessarily the case in an orbital process. Their eye should be able to also move normally. They may have some pain because their eyelid may be really tight towards their eye, and so they may have a bit of discomfort, but they'll still be able to move their eyelid fully, and it should be uncomfortable, but not particularly painful. So you need to check those extraocular movements and make sure that, it looks normal, or at least similar to the other side. And if they have less movement, that's suggestive of something obstructing those muscles. And as we've, established, the muscles are in the orbit, not superficially. And what we mean by globe is that their eyeball itself shouldn't be pushed forward. Their lids may be swollen and pushed forward compared to the lids on the other side, but the actual position of the eyeball itself should be the same. And so typically these preseptal cellulitises are due to a cut or a wound somewhere around the eye, and then bacteria gets into the superficial layers of the skin and can cause an infection. And more rarely it can be caused by other sites of infection around the eye, like dacryocystitis, things like that. And Staph aureus is the most common in these cases. And so I really do think about it as a soft tissue infection that you may find on the skin somewhere else, but just around the eye. So similar mechanisms of how it spreads, similar organisms that are the most common. And so I think that's a good way to conceptualize it in your mind. And so in terms of management, these still need to be treated pretty early to make sure that the infection does not extend into the orbit. Like we said, it's helpful that we have the septum that sort of blocks these two compartments, but if the infection brews for long enough, there will be extension into the orbit, which becomes a lot more serious to manage. So it's important that these patients are started on treatment and that they're monitored to make sure that their infection is improving, and if they're not improving, to make sure that they're followed closely. And if you have any concerns, getting a CT scan with fine cuts through the orbit to make sure there isn't any extension of the infection. And so that's sort of your basic approach to these preseptal cellulitis cases. The one thing I forgot to mention with the assessment is that the pupil exam is super important in these cases. So when you shine the light in each of their pupils, they should react the same in both eyes, because like we established, the pupil response is partially mediated by the optic nerve. And so in a superficial infection, there should be no involvement of the optic nerve. If there's differences, then that points towards an orbital process. Okay, so moving to orbital cellulitis, this is an infection that is now behind the septum or within the orbit, and you can see on that CT scan on the third photo there how there's infection or inflammatory debris within the orbit. And I just point your attention to the top photo there. The amount of swelling is looks pretty similar to the previous photo. Just by looking at a patient, you can't really tell whether they have orbital cellulitis or preseptal, because all you're seeing is the swelling on the eyelid. And so it's important to actually examine the patient and look for those findings we talked about to determine whether there's orbital involvement. And so in contrast to preseptal cellulitis, which we've kind of already established, these patients will have decreased vision oftentimes because their optic nerve is actually being compressed by all the inflammatory debris. They're going to have trouble moving their eye, and they may actually have double vision because now the infection material is closely adjacent to the muscles, and it can cause restriction and things like that. And so they'll have trouble moving their eye. They may have double vision because now their eye muscles are restricted and now their eye is misaligned. They'll have pupil abnormalities because now their optic nerve can potentially be compressed. The orbit is a confined space, so any sort of excess in material, whether that be infection or things like that, can compress these structures quite easily. And these patients will also have proptosis. And so as you can see on that CT scan, when you look at the actual position of the eyeball is pushed forward inside the skull. And so we measure this with a Hertel's ophthalmometer, which is basically a device that you place on the patient's orbital rims and measures how far forward their eye is. And I think that's always a really important piece to do as an elective student, to do a thorough assessment, is checking for proptosis. Because these 4, 5 exam techniques are absolutely critical to figure out whether there's an orbital process. So I would do this on every single patient that comes in with a potential infection, of the eye or surrounding structures, to show that there's no orbital involvement. And then, management is sort of beyond the scope of this talk, but I would always think about also on your review of systems, asking about potential sources of this infection. Because typically orbital cellulitis doesn't just happen. Typically these patients have some sort of underlying reason why they have this. And so I would work through whether you think this infection could be coming from the brain, whether there's an abscess somewhere in the skull that we're not seeing. Oftentimes these can be related to sinusitis, if patients are immunocompromised, things like that. And so I would run through that list of things to try to figure out why they have orbital cellulitis, because oftentimes there's an underlying cause for why this is going on. And then the final thing that I'll mention is that oftentimes these patients are co-managed based on the source of their infection with ENT or neurosurgery, because if they have an abscess in the sinuses or in the skull base, they may need involvement of another service. And so that's why CT scan is really critical in these patients to see if they need any sort of other specialty care. And so this is a helpful table that I would keep in mind, separating preseptal and orbital cellulitis in your mind. Anytime you see someone with an infection of the eyelid. And so even sometimes with people with styes or chalazions, I'll think through this list as well, just because they can have superimposed cellulitis in addition to their stye or chalazion. And so next one is we're going to move to the sclera and the conjunctiva. Conjunctivitis is very common, and it's also very common on exams as well, and differentiating the different types of conjunctivitis. This is bacterial conjunctivitis, and so as you can see now, this is not really involving the eyelid, it's more so the conjunctiva, which is the transparent layer on top of the sclera, is very inflamed, and you see a lot of purulent discharge. The organisms involved in this can vary. Many of them are this kind of similar skin bugs that you'll see in soft tissue infections. And the other bacteria that we have to think about is chlamydia, which can be the result of a sexually transmitted infection, or this is one of the neonatal types of conjunctivitis that you can see as well. And these also have purulent discharge. Relative to viral conjunctivitis, which I'll show on the next slide, bacterial conjunctivitis is relatively rare, and so a helpful tip that I got when I was an elective student, that as a default, most people have viral conjunctivitis, and you need a lot of evidence to point you otherwise to think that they have bacterial conjunctivitis, because oftentimes like patients will have a little bit like discharge that maybe has a little bit of a cream color to it, and you wonder to yourself whether this is purely in the discharge. But typically, people with bacterial conjunctivitis have a lot. And so I would think that people have viral conjunctivitis unless there's like a lot of evidence that would point me towards another direction. And sort of that's how I typically approach these cases. We always have to think about these more rare cases of conjunctivitis. But just highlighting that the hallmark of bacterial conjunctivitis is that the discharge is super thick, and also typically these cases are only one-sided. As we'll talk about, viral conjunctivitis typically eventually involves both sides, while bacterial conjunctivitis it typically only associates with one. And so it's important to differentiate this because bacterial conjunctivitis requires antibiotics, while viral does not. So this is viral conjunctivitis. An important sort of exam or question you may get asked is the most common virus that this is caused by, and it's adenovirus. There's rare case reports of people getting this from coronavirus, things like that, but adenovirus is the one you want to think about. And so, this is the most common type of conjunctivitis you'll see. Very common watery red eye. They'll have like watery discharge, which I mentioned may have a bit of cream color to it, but typically it's not as purulent and thick as the bacterial conjunctivitis. A really helpful exam thing that I would do on anyone that has conjunctivitis is feeling for a preauricular node, so a node right here in front of the ear. Oftentimes, the lymphatic drainage from your eye goes to that lymph node. And so actually with any patient with a red eye, I would always document that in my exam, whether they have a preauricular node, because that can provide good evidence about whether you think this red eye could be conjunctivitis versus some other case. Because, many times in the eye clinic, you're seeing these patients undifferentiated. You don't know what type of red eye they have, and it's your job to figure it out. And so documenting whether they have a lymph node here is helpful in sort of narrowing down what you think is going on. So this is viral conjunctivitis, super contagious, and there's no specific therapy. These patients do not require antivirals, and so in many centers, we actually, if we hear on the phone that we think this patient has viral conjunctivitis, we actually don't even see them in the acute phase, just because it's so contagious that you don't want to infect everyone who comes to your clinic, and that typically this is a self-resolving process. And so if we think someone has conjunctivitis, we'll typically see them a week or two after their initial presentation, and if their conjunctivitis is not resolving, then we have to start thinking about other causes at that time. But we typically don't even see them in the acute phase because most of these cases are viral and they'll get better on their own. And so that's just an important thing. If any of you take buddy call, for example, during your electives, to ask about these symptoms, maybe ask the emerge doc to feel for a lymph node, because ultimately, if you think there's conjunctivitis, you don't bring them in until like a week or two after if it's not resolving. And the other thing you want to always include in your management plan is counseling around the contagious nature of this and the importance of hand hygiene, and staying away from other people, especially within the house, so that they don't spread this to other people. So just to highlight, this is super, super common and super contagious condition that can be spread around easily. Oh, sorry, that's my pager. Um, okay, so the next one is allergic conjunctivitis, um, which encompasses a spectrum of conditions. Um, sorry, I'm just gonna get my page and I'll be right back. Okay, sorry about that. So, getting back to allergic conjunctivitis, this is the third main type that you'll also see. There's many different forms of allergic conjunctivitis. As an elective student, I think you just need to be able to differentiate this from the two other types, just because the treatment is slightly different. And so the main thing you want to elicit on history, and that I would actually ask for any patient with conjunctivitis, is whether they have atopy or things like asthma and eczema, whether they have a history of rhinitis or sinusitis, because these are potentially more in line with allergic conjunctivitis. And then on exam, I would look for whether they have papillae on their conjunctiva, which is a bit more of an advanced exam technique. And so I think my tips as an elective student for looking for papillae versus follicles on the conjunctiva is firstly, I think many people when they're starting to use a slit lamp don't appreciate that when you look at the eye on the bulbar surface, so the actual surface of the eyeball, the bulbar conjunctiva, when you look at it and you sweep across with your slit beam, it's flat, obviously. Like it looks very flush with the eyeball. But so I would first appreciate what's normal when you just look at a normal patient's eye. But these patients with conjunctivitis, if you look, those who have like inflammation, their conjunctiva will be more bumpy. So when you take your slit beam and you sweep across the eye, you'll notice that the conjunctiva is not flat. So first, I would just learn to appreciate that. And then I find that the easiest way to look for follicles or papillae is to look underneath the upper lid. So that's the photo that we have here, just because, it provides this flat surface. You can see the vessels more easily. And so you can get a better sense of whether there's follicles or papillae there. Also, typically, papillae have a whitish color to them, which is hard to see on the surface of the sclera, which is also white. But on the under surface of the lid, the sort of background color is more reddish, so it's more obvious to see whether there's papillae. And so papillae are these large mounds of white inflammatory material that you see on the bottom photo there. And so, any patient with conjunctivitis, I would always flip the lid and look under to see if you see this there, which is a bit more of an advanced technique, but I think as an elective student, really is part of a thorough assessment of conjunctivitis that you looked under the lid and try to comment on whether you think there's follicles or papillae, because as you know, that influences your differential, with papillae being more in keeping with allergic types of conjunctivitis. And the treatment is similar to viral, but you'd have the addition of like antihistamine or like anti-allergy type of medications, which is why it's important to try to parse this out. So here's a chart that you probably see in all your medical textbooks, differentiating the different types of conjunctivitis. I guess the other thing that I didn't mention is that chemosis is a little bit more specific for allergic. I will say that the chemosis is sort of a spectrum, and that sometimes you can see it in other forms. And so just because you see it isn't a slam dunk. You kind of have to take all the findings into consideration, but is a bit more associated with allergic conjunctivitis. But you can't necessarily hang your hat on it. If you see chemosis, it doesn't automatically mean it's allergic. You still have to think about the other causes. So subconjunctival hemorrhage. This is one of those diagnoses in ophthalmology where just because the eye looks really bad doesn't mean that it's actually bad. And conversely, just because the eye doesn't look that red doesn't mean it's benign diagnosis. And so, subconjunctival hemorrhage is one of those diagnoses where it looks really bad. Patients will freak out when they see this because the eye looks completely red. But this is actually a very benign diagnosis, as you know. This is essentially just a bruise of the eye. And so you've probably already, read about some conjunctival hemorrhages. The couple of more high-level things that I'll highlight for this diagnosis is that in cases of trauma, if the subconjunctival hemorrhage is 360 degrees, that is suggestive, or at least needs to make you think about whether there may be a globe rupture, just because of the extent of trauma that produced a 360 subconjunctival hemorrhage, and also the fact that in these cases, you'll see if there's a corneal laceration on the front of the eye, but when there's so much blood on overlying the sclera, if there's a scleral laceration, it may be harder to see. And so that's another reason why in these 360 degrees of conjunctival hemorrhages, you need to think about globe rupture. The other thing is, many of these cases will be just random or related to trauma, which are probably the two main causes. But I think some other things to elicit on history to try to dig in a bit more and do a higher level assessment is whether it was associated with Valsalva, which is another common mechanism. You can check your blood pressure and check their blood pressure in these cases. Many patients, as you know, come in with undiagnosed hypertension, and this is a diagnosis you could potentially make in the eye clinic. So I would just add that to your list of things to check in these cases. It takes like a minute to do, but if you find undiagnosed hypertension, you can really help that patient manage a chronic disease, which can have a lot of complications. And then finally, if it's recurrent, you may want to just do a quick review of systems for bleeding disorders. So ask if they have, bruising in other places on the body. In rare cases, this can be associated as like a first presentation of a hematological malignancy. And so ask about whether it's happened before. If it's recurrent and it seems like a bit strange how this happened just spontaneously, maybe ask about bleeding disorders, because that's another diagnosis you could make in the eye clinic that has large systemic implications. And so I would add that to your list of things to add in these cases, because even though overwhelmingly this is going to be benign and very straightforward to manage, in those rare cases where you find something by asking these questions, you'll pat yourself on the back, and it's part of a thorough assessment. Okay. So episcleritis, and we'll talk about scleritis after this, are two diagnoses that often go hand in hand, and is a diagnosis that I think often gets passed, bounced around or proposed by non-ophthalmologists. And so this is a common question we'll get in the eye clinic about whether this patient has episcleritis or scleritis, because it's a common diagnosis to think about, just because these patients have a red eye but not so much discharge, and so if you don't think they have conjunctivitis, maybe they have this. And so differentiating the two is important. The couple of things that I'll highlight is that episcleritis is the less severe of the two. I would just conceptualize that in my head, that typically the pain is a lot more mild, and so typically, as we'll highlight later, patients with scleritis have very severe pain. Episcleritis, not so severe. They'll have mild irritation, things like that. There's different types of scleritis, but the most common presentation is you'll have sectoral redness. So most of the other presentations we've talked about, the eye will be diffusely red. So if you see an eye that is only red in a certain quadrant or clock hour, that is more in keeping with episcleritis, so it can be a clue to point you in the direction of this. And the red eye will be more superficial because this is just the episcleral vessels involved. And so another thing that I like to do on all patients that have red eye is after anesthetizing the eye, I'll take a Q-tip and I'll just gently rub the conjunctiva back and forth. And if I can see the vessels moving, it suggests that it's more in the superficial layers, not on the sclera itself, which is more in keeping with episcleritis. The treatment is typically NSAIDs. Often, this will differ based on the center that you go to, and so maybe ask what your local practice patterns are. A lot of institutions, from my understanding, will use oral episcleritis for this. Sorry, that's my pager again. I'll just get that one, be right back. Okay, sorry about that. And so, yes, as we mentioned, it will depend on institution, but NSAIDs is your go-to for this. So this is just to highlight the relationship between the episclera and the sclera, as we pointed out, and the episclera is more superficial. So scleritis is the more severe of the two diagnoses, and so the main difference on history is that these patients have more severe symptoms. The pain is a lot more severe. It'll be dull, aching. Oftentimes these patients will have pain behind the head as well, which is a bit unique for causes of red eye. Typically you don't have retroorbital pain, but the pain will be a lot more severe in these cases. They'll be a lot more photophobic and they'll have tearing. When you look at their eye, scleritis can be a spectrum. So, there's different types of scleritis. There's diffuse, there's nodular, where the eye can just look red. But in severe cases, it'll look necrotizing, which is this here, which is actually the sclera dying off, and what you're seeing is the purple hue of the choroid underneath the sclera. And so these are severe cases, and is often the picture you'll see in textbooks of scleritis, but I also just highlight to you that just because they don't have this doesn't mean they don't have some other form of scleritis. So, it's important that if you see this, you need to be thinking about scleritis, but you also need to think about it even if their eye redness does not look like this. So, oftentimes history can be super helpful for you here. In terms of etiology, so episcleritis, in contrast before, is oftentimes idiopathic. That's the most common reason. In really recurrent cases, you may do a workup for autoimmune conditions depending on your institution, but scleritis is classically the one that's associated with immune-mediated diseases. So this is like collagen diseases, rheumatoid arthritis, different types of vasculitis, things like that. And so, a way that I conceptualize someone who has scleritis in my head is that you need to kind of think this is being fueled by some sort of raging vasculitis or autoimmune condition until proven otherwise. So you need to always have a high index of suspicion for working up an autoimmune condition if you think they have scleritis. And so the treatment is more intensive than episcleritis, which is why it's important to differentiate the two. Oftentimes, and again, this is sort of institution dependent, exactly what your practice patterns are, but I would say the majority of institutions will put them on some sort of steroid, usually oral, like prednisone 60 milligrams, and often for the, over the course of weeks, often associated with like topical steroids or topical NSAIDs. And, in many cases, these patients often need like non-steroid immune modulatory therapy. And so these patients are often co-managed with rheumatology or uveitis specialists to get them on that therapy to make sure that this doesn't recur. And all these patients need a workup. Episcleritis, if it happens once, you don't need to necessarily send for any blood work, but scleritis you always do. So you always need to do a thorough workup for autoimmune conditions, ANCA, ANA, things like that. It will differ depending on your institution, sort of what their standard workup is. But those are the things you need to be thinking about. And then some institutions will also get a B scan to rule out posterior scleritis, because scleritis can also affect the back of the eye, like we were mentioning at the beginning of this talk. The sclera also extends to the back of the eye, so they can have posterior scleritis as well. And so many of these patients will also get a B scan to rule out posterior scleritis, which is, affecting the sclera that you can't see. A helpful test to differentiate the two, you can utilize the anatomy here to differentiate the two. As we mentioned, episcleritis is more superficial. So if you give them phenylephrine, which is a vasoconstrictor, it will only constrict the superficial vessels. So here on the top, you see after giving them phenylephrine, the vessels blanch. So this is like after you dilate them, you come back, their vessels are, their eyes no longer red. But patients with scleritis, their vessels are a lot more deep, and so it won't blanch. Formally, the actual test for this is using 10% phenylephrine, which is a bit of a higher concentration, and not all clinics have this, but that's sort of the official test. If you have it, it's good to use. 2.5% is the sort of most common, drop you'll see that's often used for dilating patients and things like that. So if you only have 2.5%, you can use it, but the formal test is 10%. And then again, because these vessels are more deep in scleritis, if you take that Q-tip and you use it to move the conjunctiva, the vessels won't move because they're actually adhered to the sclera, which you can't move with the Q-tip. So that's everything for the sclera and conjunctiva, which is, really encompasses a large majority of the presentations you'll see. Moving on to the cornea now. So dry eyes, this is super common. I think when you make your differential, it's always important to rule out the really critical things, but also keep in mind, what is the most common, or one of the most common things this could be. And dry eyes is, something that's ubiquitous in society and is, oftentimes the final diagnosis you'll come to after doing this very extensive workup to rule out all the bad things. Oftentimes, a patient's redness and pain could be just due to dry eye. So just to always keep this as a possibility, but rule out all the other things first, because these patients can have red eyes that are very, very painful, but you need to make sure that it's nothing else before you default to the patient just having dry eye. And so, artificial tears, which is sort of like the most common thing you'll recommend to any patient who comes into the eye clinic, is, one of the mainstays of this treatment. But we also recommend gels very often. Something that I always recommend is warm compresses too, because many of these patients have this because of meibomian gland dysfunction. And so warm compresses actually helps address the underlying issue. Corneal foreign bodies is another common reason for red eye. Typically, it's a bit more obvious because these patients will have a history of trauma or something like that you'll actually see, the foreign body. A couple of tips, depending on your institution, sometimes you'll get to try to remove these as a medical student. Sometimes, you won't get to, try, but see what, your residents and staff are comfortable with. I think a couple of pearls for, foreign bodies is always make sure you flip the lid to make sure there isn't also a foreign body that's stuck under the eyelid, because that will continue to cause, irritation. So that's one pearl. I would always try to use a 30 gauge needle first, just because it's a bit less abrasive, and then ultimately, if you can't get it out, you may have to use like a diamond burr to get out the last portion. So yeah, those are always a couple things. And I think as part of your assessment, you always want to think about whether this patient could have an intraocular foreign body. So always asking about whether the patient is wearing safety glasses, whether there's a high speed or high temperature mechanism, that something could have went actually inside the eye, is always super critical to ask about on your assessment, because if there's a possibility of an intraocular foreign body, then these patients need imaging, things like that. So always include that as part of your consult. Just because you see the foreign body on the surface of the eye doesn't mean that's the only thing that's going on. Always think about whether there could be an intraocular foreign body. Corneal abrasions, these are also super common that you'll see in your emergency eye clinic. You've probably already seen them if you've done your just regular ophthalmology rotation or you've done your emergency rotation. The thing that I'd highlight here, one thing I counsel patients on is that sometimes patients, especially patients who have these injuries from fingernails or tree branches for some reason, have a small risk of developing recurrent corneal erosion syndrome, where they can actually get another corneal abrasion like months or years after, with very little trauma. Even sometimes just opening their eyes in the morning after sleeping can cause that. And so it's always something that I mention, that if they have sudden onset of this same pain again, to come be reassessed, because there's a small risk of having recurrent corneal erosion syndrome. So just a higher level thing to think about, but otherwise these are usually pretty straightforward to manage in the clinic. Bacterial keratitis, anytime there's an opacity on the cornea, we have to think about these, and it's often sort of the thing that we treat for empirically first while we try to sort out, what exactly the corneal opacity is. So this is when you always have to have at the top of your list. Always ask about contact lens wear, because it changes your differential in terms of the organism that it could be. So that's always critical to know, and it's sort of like always mentioned in your one-liner about the patient, whether they're a contact lens wearer. In terms of higher level things, because I assume many of you have probably seen ulcers already, is oftentimes these patients need to be cultured. Exactly the indications for culture will vary depending on your institution. I think if there's ever a question about whether you should or not, you should probably just do it. There's little downside in culturing, but I think institutions vary in terms of how comfortable they are just trying to treat with fortified antibiotics first before culturing. And so I think as a trainee, it's always safer to err on the side of caution and suggest culturing first. But just recognizing that some institutions will be comfortable just starting the patient on fortified antibiotics and seeing how they do. And so here in Ottawa, and I would assume most places, culture the ones that are larger, so and individual access. Herpes keratitis, whether that's herpes simplex or herpes zoster, also very common condition that causes a red eye that you'll see in the ED. So I guess the main higher level thing is that this dendrite pattern, it's like awesome if you see it, but I think you also need to have a suspicion for it, because by the time that many of these patients come to the ophthalmology clinic, they may already have been started by the emerge doc who saw the dendrite initially and have already started them on acyclovir, and so they may have like a healing dendrite which doesn't look as clean as this. And so just recognizing that the dendritic pattern isn't always this clear, and you may see like a pseudodendrite, or it looks like a pseudodendrite, and so always just having an index of suspicion to consider other diagnoses, and that many times you won't see such a clear dendrite on your exam. But again, this is usually something that you'll see a lot of, so you'll get pretty comfortable managing in your clinics. The one higher level thing that I'll mention is that I think it's always important to dilate these patients. just to rule out any involvement of the posterior segment. So you can have posterior outer retinal necrosis or acute retinal necrosis. It's very rare, but if it happens, it's very significant and carries high morbidity. So always dilating these patients to make sure that they don't have involvement of the retina. And you can look up photos online of what retinal necrosis looks like. But I would always dilate these patients to err on the side of caution to make sure that's not going on. Anterior uveitis. So this is another common thing you'll see in your emergency clinics like all the time. And so just recognizing, and I'm sure you've already gotten talks on this, uveitis is divided anatomically. So there's the anterior form, which is the most common, but the uveal tissue, as you know, extends around the entire eye and involves the iris, ciliary body, and the choroid. So you can also get posterior uveitis. You can read the slide here. Most of these cases are idiopathic. One thing that I'd highlight is, again, this will differ based on institution, but I think most people would do a sort of basic workup, even in first presentations. So, my approach is to typically test for HLA-B27 and do a syphilis test. Those are sort of like the sort of baseline workup that I would do for a first presentation of anterior uveitis. And then if they have recurrent episodes or things like that, or other features on your history and exam that point towards one of these other diagnoses, then I would treat as or test for those conditions as well. So I would just have a list of differentials to keep in mind when someone comes in with this and just ask about them. But I think on a first presentation, you really only need to test for just a few. And I'm sure you're going to be quite familiar with the treatment for this as you go through your electives. So I'm sure many of you know this. These are the findings that you'll see in uveitis. Acute angle closure glaucoma. So, in med school, you always learn that this is one of the really acute ophthalmology, diagnoses. Thankfully, this isn't as common compared to other forms of glaucoma, but is always, urgent to address. And so this is sudden increase in the intraocular pressure because the angle gets physically closed off. And this is a type of glaucoma that causes a really red, angry eye. And so oftentimes these patients can have pressures in the 40s or 60s. I would say oftentimes as an elective student, you aren't the one, managing these cases, but if you can get involved in a case like this, it's always good learning. And so you probably already know the symptoms. As a general approach to treatment, so, typically when these patients come in, it will, be after hours, for example, and, that night, the main goal of treatment is to get their pressure down first. Typically, again, institution dependent, but I think if you can send them home in a pressure under 30, most people would agree that that's ideal. And so you do that mainly by first giving them full medical management. And so that's, eye drops with every class of glaucoma medication covered. So, an alpha class, beta blocker, carbonic anhydrase inhibitor. Most people would also throw like pilocarpine in there. Prostaglandins are oftentimes, not used in the acute phase, but they can be. They can be like pro-inflammatory, and they often take a bit longer to work, and they're not as fast acting. But you want to give them like all the drops that you have, basically. Many people, I would also probably involve like oral Diamox pretty early too, like right when you see the patient, assuming they don't have kidney issues. In fact, that would probably be like one of the first, things I ask. Because if you think their pressure is like really high, like in the 40s and 50s, you probably want to get that pressure down quickly, and Diamox is a good way to get there. If it's recalcitrant or the pressure is really not coming down, you can also give glycerol, and so that would sort of be my like workup in terms of approach. You can give all these medications multiple rounds. I would probably err on the side of caution about giving multiple doses of Diamox in the same night, just because there can be side effects related to like metabolic alkalosis and things like that. And ultimately the goal of this is once you get the pressure down enough and you reduce the swelling in the cornea, you try to do a laser iridotomy to provide another pathway for aqueous to flow through. And so that's sort of the end goal in the acute management of these cases. Get the pressure down using the medications, and then doing the LPI once the cornea is clear enough and the eye isn't as inflamed. And so those would be the main approach I would use for these cases. I think another thing as an elective student, sometimes you may help a resident manage these cases. And so yeah, checking the pressure frequently, and the drops you can give like multiple rounds. Like some, residents will give like, 5, 10 rounds of these drops to try to get the pressure down. But oftentimes if the pressure isn't budging at all after your first couple of rounds of drops, that's when you really want to think about the oral options like Diamox, glycerol, things like that. One of the final pathologies that we'll touch on here is hyphema, which oftentimes doesn't necessarily give you a red eye itself, but depending on the mechanism can give you a red eye. And so this is a presence of blood in the anterior chamber. I'm sure many of you have dealt with these cases before. I think a couple of higher level things is, commenting on whether you think this is a macro or microhyphema. Microhyphema is very common, where you just don't see the blood layering at the bottom of the iris like that, but you see the blood cells floating around, similar to how you would see in uveitis. And so I would immediately classify this in your head about whether you think you're dealing with a microhyphema or a macrohyphema. If it's micro, grading the cells that you see similar to uveitis, because it helps you track the case over time. For macrohyphema, using your slip beam and measuring the amount or the height of the meniscus of the blood is also a helpful way to track these over time. So that would be one thing I would include as part of your assessment for a higher level workup. And also making sure that these patients always need to have their pressures checked to make sure they aren't developing pressure spikes. This is probably a bit beyond the scope of this talk, but we are so concerned about the pressure because if there is pressure spikes, there's like a certain level of pressure that we consider like AC washouts and things like that. And so, your job as an elective student is to make sure that you're always getting an accurate pressure, on these folks. In terms of management, bed rest 2 to 3 days at least to prevent rebleeding. A helpful pearl because, these patients, because this is often associated with trauma, these patients are often younger. Many of them are very eager to get back to work or whatever they're doing. And so, a very common scenario is that the patient will have a hyphema and they'll ask you a lot of questions about, what activities are okay and not. And so I think you have to have a very thorough discussion with them about the risk of rebleed. And that could mean like you may need a surgery or a procedure to take out fluid from the front of the eye. And typically a rule that I would say is that, if whatever activity you're proposing to do, you could stay upright and you could balance a glass of water on your head, then that activity is likely okay to do. So if you work from home and you're on a computer and you're just walking from your desk to your kitchen, that's okay. But if you work, let's just say as a server at a restaurant, you're bending, picking up stuff, maybe having to walk fast, that's likely not okay in terms of return to work. So I think that's a good benchmark that I use, and also helps the patient understand like how little activity they need to be doing. And so these patients typically are followed nearly every day for the first week to make sure they're not having any rebleeding. In the very severe cases, full blood in the eye is called an 8-ball hyphema, where basically the anterior chamber just looks like an 8-ball, like it's completely black. And that's what you want to avoid, because that can cause corneal staining, so the cornea itself is actually stained with blood and is more likely to be associated with high pressure. So those would be my pearls for hyphema. And there's a little 8-ball there. Okay, so here's a summary of the presentations that we went over today. These will encompass a lot of the common diagnoses you'll see on your electives, and I highlight here a couple of the red flag diagnoses that I would say, when you see a patient with a red eye, you should probably be thinking about all of these, but in particular, you should always be thinking about the red flag ones, because those are the ones that are serious, potentially vision threatening, and that also require, more urgent treatment. And so I think as a learner, it's always important to be systematic and always consider these diagnoses. And as you become more senior and you see more presentations, you'll develop pattern recognition and it'll become more, second nature to you. But especially as early on as a trainee, I would always have an approach. Sometimes I physically keep a list on my phone of the diagnoses that I need to think about, right before walking into the room with the patient. And so, I think as an elective student, don't feel the need to see patients really quickly, but I think being thorough is, more important and is more indicative of your future performance as a resident. Being thorough in your assessments, and the speed and the efficiency will come after once you develop a really foundational approach, because if you look at this list enough, it will just become second nature to you about the things you need to think about. And so that would just be my general advice for, approaching any presentation, as an elective student. You always want to try to be, thorough and think about the most important things. So, these are the diagnoses that we touched on, and these are some of the red flag symptoms. So, many patients will come to you with a red eye, or if you take buddy call, you'll get many calls about red eyes. And so, these are always the things that I would want to know over the phone. Some of these things are, hard for a non-ophthalmologist to reliably comment on. Things like seeing cells in the AC. Like, most people can comment on whether there's like an 8-ball hyphema, or in a light iris whether there's blood pooling at the bottom of the AC. But being able to see if there's cells in uveitis or hyphema is a more advanced skill. And so it's also, partly trying to know what questions you can ask and what is something that a non-ophthalmologist can comment on. So getting a visual acuity, things like that, whether you can see a corneal opacity. I often just ask, like, does the cornea look clear, or do you see a white spot on the cornea? And I would take any sort of white spot as, quite serious. It may not actually be a corneal ulcer, it may be something else, but if they say that they have concern about a white spot in the cornea, I would take that pretty seriously. And so these are all red flag symptoms that I would ask about. Again, I would keep this list on your phone and keep it handy for you to refer to, and always come back to this list before you see any consult. Because that's, I think, the benefit as a medical student is you typically have some time to formulate your thoughts about cases before you present. And so, just make it easy on yourself by having this list handy, or having a list handy, as you go through your electives. And I think the other thing that we talked about is, when or when not to dilate these patients. And, you can, always dilate the patient later after they've been assessed by someone, but you can't undo a dilation. And so just another thing to keep in mind. And I'd want to prioritize, not potentially jeopardizing the patient's assessment that day and having them need to come back at a later date. Okay, so here is a summary of all the presentations that we went over today. So hopefully this can be helpful in terms of differentiating these presentations in your head. And again, at first, it's going to be a lot to think about and a lot of questions to ask, but over time you'll start to develop a sense of pattern recognition. And then differentiating the different types of episcleritis and scleritis, and some of the pathologies in the anterior chamber. And so, a lot of these come with experience, looking at a lot of eyes, being able to tell some of these presentations apart. And so that's all the presentations and conditions that I wanted to go over today. So I hope you found this presentation helpful in terms of developing an approach to the red eye. And hopefully this presentation was able to provide a few higher level pearls that I think can be helpful as an elective student when you kind of want to take your assessments to the next level in terms of, being thorough and using some higher level techniques as you go through your medical school electives in ophthalmology. I would welcome any feedback on this presentation. Some of these practice patterns are institution dependent, and so I would certainly recommend asking, residents or staff at your local institution to see what the practice patterns, are there at your center. But would welcome any feedback on terms of the content of this presentation, and hope you found it helpful. And if you had any questions, my email is there. And so, best of luck on your electives. It's a really exciting time in your medical school career. And although the residency match can be stressful, I wish you the best of luck. And, I hope that over the course of your electives, you're able to develop a passion for ophthalmology or whatever specialty you choose. Because I think regardless of what happens in the match, a passion for medicine will take you a long way in your career, regardless of what that looks like. So thanks for listening, and good luck.